Okay, we're going to go ahead and get started here. Welcome, everyone. My name is Jenny Glenn Gingery. I'm the Associate Director of Communications and Media Relations at the Endocrine Society. Thank you so much for joining our ENDO 2020 virtual news conference on diabetes. We really appreciate everyone being flexible and joining us digitally. We're very pleased to have with us Dr. Gloria Wu from the University of California, San Francisco, Yingying Luo, a visiting scholar at the University of Michigan, and Dr. Tali Kukerman-Yaffe from the Sheba Medical Center and the Sackler School of Medicine of Tel Aviv University in Tel Aviv, Israel. Unfortunately, Dr. Robert Vigurski could not be with us this morning as scheduled, and we apologize for any inconvenience. Over the next 30 minutes, each speaker is going to be presenting their findings. We'll have one Q&A session at the end of our time today. So everyone should be muted except our presenters. We're just doing this to avoid any distracting noises like typing, sirens, dogs, that sort of thing. If you could be sure to type your questions into the chat window. Once all the speakers have finished, I'll be going ahead and we'll be taking those questions. I'll be reading them out loud for the benefit of anybody who can't see the chat window for some reason. We are recording this and it will be aired on our YouTube channel and our online newsroom after the fact. So again, thank you for joining us, and I'd like to go ahead and introduce our first presenter, Dr. Gloria Wu.
Hi, thank you for having me. Good morning. I'm Dr. Gloria Wu. Our topic today is meibomian glands in the diabetic patient. Is it a biomarker? My team is Danya Momin, Shannon Liu, Brian Lung. We have no disclosures. Next slide, please. So I want to talk about the background and the purpose. What is meibomian gland? Those are the glands in your lower lid. If you look in the left-hand side of the screen, the picture there, you have these vertical striations. They create the lipid layer of your tear film. There are 3 layers of your tear film. The middle layer is the aqueous made by the lacrimal gland, the pink oval there in diagram between the eyeball and your eyebrow. And the inner layer is glycoprotein made by the cornea. If you're missing any of these layers, you will have dry eye and some discomfort. Some people have severe discomfort and pain. So 7% of the United States have dry eye, 16.8 million people, and 57% type 1 diabetics and 70% of type 2 diabetic patients have dry eye and complain of dry eye. The purpose was to evaluate dry eye in the diabetic patient using infrared imaging. The infrared imaging is that you see on the lower left corner, that photograph. Some people speculate that why do they have in diabetes this problem of meibomian gland dysfunction? They think of microischemia, loss of blood vessels, or that inflammation, because diabetic in some cases have greater inflammation in various blood tests. So we will look at some of this. Next slide, please. The methods, we did a retrospective study looking at 2017 to 2019 EHR, eClinical Works in our clinic, and we used the ICD-10 diagnosis code of diabetes, dry eye, hemoglobin A1C. Infrared imaging was done, Heidelberg Spectralis, what's our machine here that you see in the upper right-hand corner, 820 nanometers. Lid photos were done, eye exam. And the percent loss of meibomian glands per eye was calculated and averaged per person. The inclusion criteria were, if you were control, we designated as 5.7% hemoglobin A1C, and diabetics were over 6.0% or 6.0. Exclusion criteria, less than 18 years of age, greater than 90 years of age. Glaucoma medications, eyelid surgery, or cornea surgery. Next slide, please. So the results, on the upper left-hand corner, you see normal meibomian glands, these vertical striations. On the right underneath it are areas of absence where there are none. So taking the first 120 consecutive patients, we found 67 males, 53 females. The average age was 69.6 years. The controls were 37 males, 23 females, average age 54.1 years. The diabetics were 30 males, 30 females. The average age was 65.1 years. And the loss of meibomian glands, the controls 11.3%, diabetics 51.5% is the student t-test. Looking at the chart on the right-hand side, the red circles show the control group, and you see that lower hemoglobin A1C was associated with less of a loss of meibomian glands. And the diabetics are the blue circles with greater hemoglobin A1C on the x-axis. You'll see greater loss of meibomian glands. Next slide, please. Looking at the controls, splitting it with less than 5.5% hemoglobin A1C and greater than 5.6% hemoglobin A1C, we found those with the lower hemoglobin A1C to have a loss of meibomian glands of less than 17.5%. And in diabetics, where the hemoglobin A1C was 6.5 or less, and those with 6.6% hemoglobin A1C or more, the loss of meibomian glands greater than 40% were in the higher hemoglobin A1C group. And taking all comers in our study, N equals 120, dividing it with less than 5.9% hemoglobin A1C and less, and those with greater than 6.0% hemoglobin A1C. Again, the loss of meibomian glands less than 24% were in the lower hemoglobin A1C group, and the greater loss of meibomian glands, greater than 25%, were in greater than 6.0 hemoglobin A1C. So next slide, please. So in conclusion, patients with dry eye and diabetes, loss of meibomian glands is associated with elevated hemoglobin A1C. Next slide. Next, in the future, we hope you'll take your iPhone 10, iPhone 11, Samsung 10, flip your own eyelids, look at your meibomian glands, and we hope that in the clinic, in rural health clinics, in community health centers, we can use this device that people have and evaluate when people complain of dry eye and they have diabetes, consider sending them for more diabetic monitoring and looking at their hemoglobin A1C. Thank you.
Thank you so much, Dr. Wu. We really appreciate it. Next, we're going to have Ying Luo speaking from the University of Michigan.
Hi, hello everyone. It's my great pleasure to present our study at ENDO virtual meeting today. I'm Ying Luo from University of Michigan, and today I would like to present our study showing the presence of diabetes diminishes the ultimate weight loss after bariatric surgery. Next, please. I have no conflict of interest to declare. Next, please. So as we all know, obesity is common, serious, and costly in US. According to the data from CDC, even back to 15 years ago, there were already more than 1/3 of US adults affected by obesity. If overweight is included as well, this number goes even higher to more than 50%. Next, please. Bariatric surgery has been approved as an effective way to treat morbid obesity, and it can not only reduce the body weight, but also lead to remission of many metabolic disorders such as diabetes, hypertension, and dyslipidemia. Next, please. However, how much impact their diabetes before surgery would have on the weight loss is still unknown. Next, please. So to answer this question, we performed a retrospective study by analyzing the data from a bariatric surgery cohort at University of Michigan, followed for at least 5 years. All patients undergoing bariatric surgery from 2008 and 2013 were included in our cohort. During this time, adults with a BMI over 40 or a BMI over 35 with comorbidities could undergo bariatric surgery. And patients undergoing both Roux-en-Y gastric bypass and sleeve gastrectomy were enrolled in our cohort. We have almost equal number undergoing the two surgeries during this time, 380 in gastric bypass group and 334 in sleeve gastrectomy group. However, I have to remind you that the proportion of the patients who underwent bypass and sleeve gastrectomy was changed as time went on. There were more bypass done at the beginning, while after 2012, sleeve gastrectomy has become the predominant surgery type. Next, please. At each year, we collected the demographic data as well as laboratory data. And we should note that the availability of data may be varied. For example, patients without diabetes would not have hemoglobin A1C assayed. Okay, next, please. When the baseline characteristics of the groups were compared, we see that patients in sleeve gastrectomy group were more obese, while glucose parameters and total cholesterol is higher in bypass group. Since there may have more patients with diabetes in bypass group, we presume that more patients might take metformin, which likely led to lower vitamin B12 level in bypass group. Next, please. As most of the real-world follow-up study, some patients were lost of follow-up. However, you may see that about 2/3 of the cohort were followed for at least 5 years, which we think is still a good follow-up rate in a real-world setting. Next, please. Before I show you the results, I would like to explain some terms we use to evaluate weight loss outcome. Total weight loss is the difference between initial weight and the last measured weight. And total weight loss percent is the percentage of total weight loss to initial weight. Excess weight means the difference between initial weight and ideal weight, which is the body weight for BMI at 12. And the excess weight loss percent is the percentage of total weight loss to the excess weight. Next, please. First, we performed a generalized linear mixed model analysis to compare the probability of achieving BMI under 30 or achieving excess body weight loss 50% or more for patients with or without diabetes. We found that the presence of diabetes at baseline substantially impacts the probability of achieving both indicators. Individuals without diabetes has 1.5 times higher chance to achieve BMI under 30 as shown in this table. Next, please. And same with the other endpoint. Individuals without diabetes had a 1.6 times higher chance to achieve excess body weight loss of 50% or more. Next, please. We then further conducted a linear mixed model analysis to determine if diabetes is a predictor of the future weight loss, percentage of total weight loss, or percentage of excess weight loss over 5 years of follow-up. This analysis further confirmed that after adjusting the time, surgery type, age, gender, and baseline weight, there was still a significant difference of percentage of excess weight loss between individuals with diabetes versus individuals without diabetes. And same results were seen with absolute weight loss and percentage of total weight loss, which are not shown here. And these analyses indicate that the presence of diabetes before surgery is a predictor of the future weight loss outcomes. Next, please. To better demonstrate the impact of diabetes on the weight loss outcome, we then calculate some weight loss outcomes in total population as well as in each surgery group. Here, the blue line indicate patients without diabetes and orange line indicate patients with diabetes before surgery. There is a distinct separation between two lines, and patients without diabetes lost much higher percentage of excess weight than patients with diabetes at almost all 5 visits. However, this difference was diminished after 3 years in the total group, but still completely preserved in the gastric bypass group even after 5 years. Next, please. And same trend was seen for the reduction of BMI points. After 1 year, if we look at the total group shown in the upper figure, we can see that the presence of diabetes at baseline diminished weight loss by 1.7 BMI points, which is roughly 15% of the total BMI points to be lost at year 5. This impact is even more significant and lasts for at least 5 years in patients who underwent gastric bypass surgery as shown in the lower left figure. Next, please. Here we see the same trend in the percentage of individual achieving BMI under 30. And next, please. And the percentage achieving excess weight loss more than 50% or more. Next, please. So our study demonstrates that having bariatric surgery before developing diabetes may result in greater weight loss from the surgery, especially within the first 3 years and in the patients undergoing gastric bypass surgery. Although our study doesn't have very large participant number and follow-up is only for 5 years, we do think our study opens the door for further research to understand why diabetes diminishes the weight loss effect of bariatric surgery. Next, please. And finally, I would like to express my sincerest thanks to my mentor, Dr. Ali Farrell, as well as all the members in our team. I would also like to thank all of our collaborators for their tremendous work. Okay, thank you for your attention.
Thank you so much, Dr. Lua. I would now like to introduce Dr. Kukerman-Yaffe.
Can you hear me, Jenny?
Yes, we can. Please go right ahead.
Hello, Jenny?
Hi, Dr. Kukerman-Yaffe, can you hear us? It looks like we're having a little bit of a technical glitch. Just hold on one moment, please.
Jenny?
Better, yes, we can hear you now.
Yeah, okay, great, okay. Thank you for this opportunity to present here today for all my co-authors on the relationship between the glucose control and cognitive function in people with diabetes after a lacunar infarct. Next slide. Can you move to the next slide, Jenny? Can you move to the next slide?
Oh, yes, we have. I think there's a delay on your end.
Okay, so you've moved to the next slide. Okay, so you can move to the third slide. Okay. So you've moved to the third slide because I don't see it. Okay. So stroke and diabetes are strong risk factors for both dementia and cognitive dysfunction. Lacunar infarcts account for about 25% of the stroke, and 50% of those who have a lacunar infarct develop cognitive impairment over the subsequent years. With diabetes, so we know that compared to people without diabetes, people with diabetes have a 1.5 to 2-fold greater risk for cognitive dysfunction, for dementia, and for an accelerated rate of cognitive decline. Thus, understanding potentially modifiable risk factors for cognitive dysfunction in people with type 2 diabetes who experience a lacunar infarct has important public health implications. And one such factor may be glycemic control as assessed by the A1C. Thus, next slide. We use the data from the secondary prevention of small subcortical strokes, the SP trial, in order to assess the relationship between glycemic status and cognitive function in people with diabetes after a lacunar infarct. Next slide. So this was a prospective cohort analysis from the SP3 trial. The SP3 cohort included individuals over the age of 30 with recent symptomatic subcortical strokes with no evidence of cortical strokes and no evidence of severe cognitive or functional impairment. This analysis pertains to the 942 individuals who participated in the study, also had diabetes and had available A1C values, cognitive and imaging data available. Next slide. Participants underwent extensive cognitive testing. The primary outcome was the change in the CASI score, a measure of global cognitive function, and also domain-specific tests as shown here. Glucose control as assessed by the A1C was measured at each site. We assessed both the association between, could you move back? Not yet, sorry. So we assessed both the relationship between the baseline A1C and the baseline cognitive function, the effect of baseline A1C on subsequent cognitive decline as assessed by the various tests, and the relationship between the change in A1C and the change in the different cognitive tests. So just to give you a feel of what type of population we're talking about, this is a mean age was 63, 30% had any college education, and baseline MMSE value was 27.8. So we're talking about a cognitively intact population. Could you move on to the next slide? So in this figure, you can see the relationship between the baseline A1C and the baseline CASI Z-score. And you can see here that after we adjust for age, education, and race, every 1% higher A1C was associated with a 0.06 lower baseline standardized CASI Z-score. And as you can see in the subsequent models here, this relationship persisted in all the models after adjusting for cardiovascular disease and cardiovascular risk factor, for obstructive sleep apnea, and for different diabetes complications. Can you go on to the next slide? This figure demonstrates the relationship between the baseline A1C and the change in CASI Z-score over time. There was a statistically significant relationship between A1C and the CASI Z-score over time, with a significant P4 interaction. And this relationship persisted again after multivariate adjustment. Next slide. This slide shows the relationship between the change in A1C over time and the change in CASI Z-score over time. And you can see that a 1% increase in A1C over time corresponded with a CASI score decrease of 0.021. And again, as you can see, this relationship persisted in all the models. For the other neuropsychological tests, there was a significant relationship between the change in the cognitive scores and A1C for the clock making test, the test of executive function, for the test of discriminability, and for a test of verbal fluency. Next slide. So, to summarize, this analysis of 942 individuals with diabetes who suffered a lacunar infarct demonstrates an inverse relationship between baseline A1C and baseline cognitive function, subsequent change in cognitive scores over time, and between the change in A1C and the subsequent change in cognitive test scores over time. Next slide. There are many explanations for the observed relationship. First, it may be that individuals with cognitive impairment have difficulty managing their disease and thus have worse glucose control. Second, hyperglycemia may accelerate the rate of cognitive decline by either reducing capillary perfusion or accelerating large vessel disease, or directly damaging the brain. Next slide. So to conclude, we have shown in this analysis that in individuals with diabetes and lacunar infarct, there is a relationship between higher A1C and a greater decline in cognitive test scores over time. And more studies are needed in order to confirm these results. And intervention studies are needed in order to delineate if better glucose control could slow the rate of cognitive decline in this high-risk population. Thank you.
Thank you so much, Dr. Cukierman-Yaffe. I'd now like to open the floor up to questions. If you could please type your questions into the chat window, and please include your full name if it doesn't appear on your login, as well as your institution, and then I'll go ahead and be reading those to the presenters. Dr. Lua, I have a question from Regina Schaefer of Endocrine Today. She asks, can you speak to how having diabetes may complicate weight loss?
Can you hear me?
Yes.
Okay, just to briefly answer this question, because we see that the having diabetes, there have an impact of the weight loss, but actually the mechanism we still don't know. We think that from the previous studies, there are studies showing that the bariatric surgery will have some impact of the gut hormone, which is pretty important to the diabetes pathogenesis and diabetes control. So we do think maybe this bariatric surgery has, especially the different type of the bariatric surgery, maybe have the different impact of the gut hormone, which leads to the results we found. And Dr. Rell, do you have any comments on this question?
Sure. Yeah. I mean, the mechanism, as Ying said, is not quite known, but we do know that even with medical weight loss, diabetics do worse compared to non-diabetics. So it could be that the establishment of diabetes changes something permanently, perhaps in hypothalamus, perhaps in the target tissues, such as brown fat or muscle. So the short answer is that we don't know, but there are quite a few possibilities, and it may be commonly shared in all settings of weight loss, both with medical weight loss and in surgical weight loss. It will be interesting to tease that out.
Great, thank you. I have another question for Dr. Orell and Dr. Lua from Sherry Roan at Everyday Health. How might your findings change the way patients considering bariatric surgery are counseled regarding when they should have surgery?
Together with the data that is available from the other studies, we know that actually bariatric surgery may potentially prevent or delay the onset of diabetes. But at this point, we still don't know. We have to have a larger sample size to repeat our study. If we can find that there is a true impact from the presence of diabetes, maybe it suggests we should move a step forward to perform the surgery.
I may just add that, I think our findings just highlight at least consideration of bariatric surgery coming to the table perhaps a teeny bit earlier and not wait until all the complications are established. If someone has BMI over 40 and is on the way to developing diabetes, maybe we shouldn't really wait until diabetes is established, because that will reduce some of the effects that we will see after surgery. It's as Ying said, it's probably early. This is only one data set, but we should rapidly look at other larger data sets and confirm these findings.
Great, thank you. For Dr. Wu, Jill Roulette from Endocrine Today would like to know, how is dry eye treated and what role may reducing HbA1c play after the loss of the meibomian glands?
Currently, dry eye is treated in most people, ophthalmologist's office with artificial tears. Then if it's severe, Restasis, which is a cyclosporin compound, or Zedro, which is a similar anti-inflammatory. Now, those two compounds, act on the lacrimal gland, which is the middle sandwich layer. None of them act on the oily gland, which is the loss of meibomian glands. So this tear film chemistry is, really being worked on the last 5 years, but not a lot has changed in what is available to the patient. So a lot of patients will be told that that too bad you have dry eye, just live with it, which is unfortunate, because not a lot has been looked at for patients with diabetes and dry eye, because they have specific problems. They have microischemia, they have poor capillaries, perfusion along the areas where there are no meibomian glands. There's just like empty spots. And then there's the thought that because the meibomian glands die out? Is it because they become so inflamed from previous micro-infections that the inflammation causes the death? So there are two mechanisms. And some people think that inflammation is common in diabetics as they have abnormal other inflammatory markers.
Thank you. I have two questions for you, Dr. Wu, from Miriam Tucker at Medscape. Is the loss of the glands permanent, or would they return with improved glycemic control? And she also asks, does this assessment add value clinically if A1C blood glucose is already being measured?
It adds value because it's a simple look, you know, another diagnostic way of looking at diabetes. You know, dermatologists look at, you know, skin, nails, and all this other stuff. And we can look at smokers and microischemia in their skin. But this is a very simple way. You turn the black and white portion of your iPhone, you put on the photo part, instead of where it's usually color, you swipe towards the right and you'll see black and white. And unbeknownst to most people, but I checked this out, is that we have infrared camera capability in all our smartphones, starting with i8, the iPhone 8. So it's very interesting. You can just, and they don't really tell you how they do it, but I did ask a bunch of researchers. So it's an easy way to look to see if something's happening to those glands. Now, I found that in my patients who are not diabetic, after 6 months of intense dry eye treatment, they get improvement. Their glands grow back. So that's interesting. I have not looked at it in a systematic way of diabetic patients to get them to do the intensive artificial tear treatment, and then a subgroup of those taking the cyclosporin or other medications. They have so many other things to think about, the diabetics, you know, their hemoglobin A1C, their diet control, their exercise control, their Medtronics, their Bluetooth device. This is sometimes hard for them to add, but it is good for us as clinicians to use this simple way of looking, one more way of looking at their diabetes. You know, instead of looking for a foot ulcer, let us look at this as well.
Thank you. Dr. Kuker-Medyafe, I have a question for you from Kristen Monaco with MedPage Today. She's wondering, should doctors be regularly screening their diabetes patients for cognitive changes? Oh, let me see if she's still on here. Oh, Dr. Kuker-Medyafe, are you able to hear me? I think she's having a connection issue, maybe. Oh, Dr. Kuker-Medyafe, I do have a question for you from Kristen Monaco from MedPage Today. Can you hear me?
Now, and just it stops every few minutes. Could you repeat the question, Jenny?
Absolutely. This is from Kristen Monaco with MedPage Today. She's wondering, should doctors be regularly screening their diabetes patients for cognitive changes?
Should doctors, sorry?
Regularly screen their diabetes patients for cognitive changes.
Hello? I'm sorry, but there was an interruption in the connection. And could you repeat that again?
Yes, it's from Kristen Monaco with MedPage Today. She's wondering, should doctors be regularly screening their diabetes patients for cognitive changes?
So the current recommendations by the ADA, by the Endocrine Society, by many European and organizations, and by the IDF actually, are that people with diabetes should be screened for cognitive impairment, and that cognitive assessment should be part of the routine checkup of people, of older people with diabetes. And the reason for that being, one is this relationship between cognitive dysfunction and self-care, and the other is that cognitive dysfunction is another complication of diabetes that we should be looking for, that is especially important in older age. So yes, definitely. I think that cognitive function should be evaluated in older people.
Wonderful, thank you. Thanks everyone, that's all the questions we have. If anyone has a last minute question, please type it in the chat window. Otherwise, we're gonna go ahead and sign off for this news conference. Again, if you can join us again at 2 o'clock Eastern today, we're gonna be talking about abstracts on endocrine disrupting chemicals. Oh, I have one more question here for Dr. Wu. This is from Elizabeth Havlinka at MedPage Today. Were patients different in other characteristics such as age or presence of comorbidities that may be confounding the elevation of HbA1c observed?
The controls were slightly younger, but the age range was about the same. So the control, the average age was 54.1 years, and the diabetics was 65.1 years. So there's a slight maybe age difference, but not a lot, because the range was about the same. It was hard to get the data of retrospectively of controls or patients who had hemoglobin A1C anyway coming into our study. And it was not a prospective study, but that's a good question, because they do think that with older age, you have loss of meibomian glands anyway.
Great. Again, well, thank you so much to all of you for joining, and for our speakers for joining us. We really appreciate it. Thank you so much for coming. And again, we'll be back here at 2 o'clock Eastern to talk about endocrine disrupting chemicals. Thank you.
Thank you.